Hi, welcome to the Taproot Therapy Collective podcast. I'm here with Dr. Haley Beach and Dr. Madeline Eckenrode. Haley is a doctor of philosophy and social work. Dr. Eckenrode is a medical doctor who just wrote an article that we saw on AL.com about Medicaid expansion and some of the effects of not having access to healthcare on women and young adults. I will let you lead us in because we want to kind of look at the way that some of these things affect Alabamians and probably people in other states too, with similar realities, and hear from the people who provide care about that. Mr. James Waits at our practice sees his specialty as physician burnout and nurses and executives and doctors, and so he may pop in if he's able to. And Haley's specialty. Well, I'll let you. Haley, can you talk about your work, just so we know where everyone's coming from before we start the discussion?
Yeah. So my work really focuses on looking at birthing individuals, women who experience violence, and women who experience trauma through their birthing experience prior and after. And so my work is really focused on that academically and professionally, as a therapist, wanting to work with that population, those women, but also interested in young adults and how they receive care and how they are able to navigate mental health in a time of life that can be very complex.
Yeah, and so and then I do trauma therapy, and so we're all kind of looking at similar population from different angles, similar issue from different angles. So just to make sure everyone knows where we're coming from. So Dr. Eckenrode, could you tell us a little bit about your article and some of your perspective working at UAB and what you see there and the effect that it has on just real people's lives?
Sure. Yeah. So I am a med-peds physician. So I did a dual residency in internal medicine, so kind of adult medicine and pediatrics. And so graduated in 2015 or in 2019 from residency at UAB, did my training there. And then I now do mostly adult primary care. But I also specialize in young adults with complex medical conditions. So I have a clinic at UAB called the STEP Clinic, where we see young adults who have very complex medical conditions from childhood, things like cerebral palsy, spina bifida, but also kids who have had organ transplants, kids who have like complicated immunologic things like lupus, things like that. So see a lot of those young adults in my practice at UAB as well. I really see the impact of underinsurance or lack of insurance every day in my life, in my practice. So I guess I wrote the article, I think after years of kind of being like, why hasn't this happened? Why haven't we expanded Medicaid? Because I just see how it impacts my patients every day. And I think I was talking to an organization called Alabama Arise that does advocacy around lots of issues that affect Alabamans, including the lack of Medicaid expansion here, and was talking to them about this patient population of young adults. And they were like, oh, wow, this is something we haven't thought about. So young adults who have chronic conditions of childhood, things like Crohn's disease, or they've had an organ transplant or type 1 diabetes, and then they lose pediatric Medicaid at age 19 unless they have parents who have health insurance that they're able to be covered under. They were like, this is an interesting population to write about. You should consider doing an op-ed. And so I did, and it was published and had a really, I think, good response from people who I got a lot of emails and pages and messages from colleagues who are like, I'm so glad you talked about this because it's something that is very real. We see it every day. And so I've been really gratified to hear that response from people who are like, this is an issue that is under discussed.
Well, and I'm glad to see more medical professionals, especially doctors who are kind of the top of the food chain for the medical establishment, talking about that, because I think not talking about it leads to these kind of confusions about like I mean, a lot of people that I encounter, we've all, as Americans, probably had pain points with the medical system. I don't know that anyone is loving it. Or like any kind of political advertisement that pretends that like people love the healthcare system, it doesn't make sense to me. Like I remember when Obamacare was first being discussed, and people were like, "Your precious insurance plan, you might lose it." You know, like don't we all curl up by the fire with our insurance plan, you know, every night and hug it and kiss it on the forehead? And it was like, cable companies, airlines, uh, insurance, like these are things that I don't know that anyone's having a great experience with. But I think a lot of that anger gets directed at doctors in ways that aren't fair by people who don't really understand how that system works. And it makes sense because the doctor is the one telling you I don't have time to see you, or the scheduling for UAB is the one telling you, well, yeah, there's something 7 months from now if you want to get a referral for therapy, but you have to have primary care first which is Blue Cross Blue Shield's decision, but it feels like the white coat is out to get me. And a lot of that, I mean, I understand the reason you wouldn't want to talk about some of these things, but it seems like the response to your article has been good. I wonder if you could say anything about that engagement, good and bad, in the conversations that maybe you see.
Yeah, I think that's right. I think there's been a loss of trust towards doctors, and that's a very complicated and we don't, that's not kind of the topic of this conversation, but yeah, I think that being transparent about some of the struggles that we have to care for our patients effectively is good, so patients know that. And I always try to be honest with patients, and I think that a lot of times patients think that anything we say can overcome insurance company barriers, and that's not always the case. And so it's often not the case. I've like literally cried on the phone with insurance companies doing prior authorizations because I'm like, if you deny this, like this patient might die. And then usually it does get approved, but like then I have to like cry, like that's crazy. But anyway, yeah. So
well, and why are you the one telling them? I mean, one, why are they the one telling you that you need to change your medical care as the one who's licensed to provide it and has the encounter with the patient and the access to the test results and like all the healthcare data? And then why are you the one begging them to explaining to them that the patient might die? I mean, what is that system?
I don't know. And prior authorizations required for like generic medicines like albuterol. It's like albuterol is a life-saving medicine. It's a generic medicine. It's been around for 50 years. Like, why do I have to
It's not even expensive. Like, why are you gouging them?
Yeah, so it's really crazy. And I probably do like 4 hours of paperwork every week related to medication, kind of prior authorization and stuff like that. And so and that just stinks. But yeah, so insurance kind of is the enemy as far as I'm concerned, in terms of preventing good care for patients, and huge money making corporations that don't care about patients at all. I think a lot of stuff about United Healthcare that has come out is true and is bad. Like there was just a ProPublica article about how they in certain states use algorithms to see how if people are using too much mental health care. And then they start
who's they here?
United
Okay.
Healthcare.
Gotcha.
So United Healthcare in certain states, it's been outlawed in a handful of states, but in certain states they look at healthcare claims by individual, and if they're using too much healthcare, mental health care, so getting too much therapy, is there too much such a thing? But they think there is, and then they start denying their claims, which, as you know, for people with like serious psychiatric illness like schizophrenia, like they need
bipolar, where you're clinging to your ability to make good decisions before you go into mania, and they can feel it and they're begging for help. I mean, those are the cruelest phone calls we get, because I can't prescribe medication. I can tell you how long the wait is, and that is dour, answer.
Exactly. So that was just revealed that they're doing this in certain states and have algorithms to look at these claims. So anyway, they're the enemy as far as I'm concerned. However, it's people do need insurance to get care, and Alabama Medicaid is actually like fairly decent, like in terms of at least prescription drug coverage. So I see this happen a lot where people they like fall off and on Medicaid, especially young women. You've probably seen this, Haley, who have babies and then they're on Medicaid, for that time, and they get a little bit of access to care, and then, that Medicaid goes away, kind of. And so then their health suffers. And so I see that in my practice a lot. Like I'll see people for a couple of years and then I won't see them for a year or two because they've lost insurance, and then their diabetes becomes really poorly controlled. And it's like, why do we have that? Like, why can't we have a system where like people can get care when they have job loss, or when they're having to care for a relative, or when they have a serious illness themselves that sidelines them? And this is a very personal thing for me. So I have a brother who struggled with addiction, and he's in Pennsylvania, and he was able to have Medicaid, which actually paid for his recovery. So at a recovery center, and also paid for mental health care, and paid for therapy, and paid for him to see a psychiatrist. And now he's been in recovery for about 6 years. And he's had a full-time job that whole time. He has a wonderful girlfriend. He's a tax-paying citizen. But if he hadn't had that Medicaid when he was in his 20s, when he was struggling with addiction, he would be dead. And so it's like, but now he's living a really wonderful full life. And it's like, why don't we want everyone to have that safety net of insurance coverage when they need it to help them like stay healthy, get healthy, and then hopefully one day, get jobs that have employer sponsored healthcare. But not everyone can do that. But a lot of people can, as long as they have a little bit of help through vulnerable times.
Haley, you do some work with people that have, caregivers with kids with chronic issues and different things. I wonder, from your background and research, if you could tell us some of the statistics about Alabama and anything you want to respond to there.
Yeah. I mean, kind of to bounce off what you were all saying, I mean, our healthcare system is so reactionary versus being proactive and trying to keep people healthy, and preventative care is so critical. But often that is not the focus of healthcare. It's when we get to crisis, chronic conditions that are so difficult at some point to be able to manage, and we're having to make tough decisions as providers and support our clients and patients in those decisions when there really are few options. I know for the populations I work with, the birthing community, Medicaid is huge. The majority of women, a lot of women use and rely on Medicaid. And the Medicaid expansion that took place post-COVID, where they expanded postpartum care for 12 months, was really critical. And I think one of the most important things that they could have done, because statistically we know that women, while they do experience postpartum and can have a lot of physical and mental manifestations postpartum within 6 weeks, really we're seeing that women are experiencing the highest rates of postpartum depression and postpartum psychosis, and these conditions up to 12 months. So really, when you have 1 6-week postpartum visit, you're barely into being a parent, coming out of birth, and then you're just dropped. You don't have care. And so that expansion was really critical to allow women to continue to receive care, where we see the majority of postpartum mortality is after. Maternal mortality is postpartum primarily. And so that was really critical. I wanted to ask about the new Medicaid expansion. Are you familiar with how they're expanding the first 60 days while getting on Medicaid for pregnant women?
I was reading about it, and I think KIV is about to sign that into law, and so I think that is for Oh, okay. Yeah. So basically, kind of making it a lot easier for people to get on Medicaid when they're pregnant and like removing some of those barriers. That's what I understood. I don't take care of pregnant women. So I was like, that sounds good, of removing those barriers. But I mean, I have some young patients who do get pregnant, but I'm not an OBGYN. But it seemed like there were some barriers to signing up for Medicaid when you are pregnant, and that Medicaid law was removing those barriers. That was what I understood. So
Yeah. Okay. I mean, I think that's how I understand it too. I think, in theory and practice look very different. So I think it seems like a good thing. And I think that it's going to be a positive move, but it'll be interesting to see how it actually plays out for women, because I think that's where it really, we see the impact of these policy decisions trickling down, directly affecting individuals in the community. I did have a question for you around the Medicaid gap, and particularly with your population, as far as those individuals as young adults who don't qualify. They don't make too little to qualify for Medicaid, but they make too much. Sorry, opposite way. They make too much to qualify for Medicaid, but they don't make enough to really have like Blue Cross or a private plan. What do those individuals do? How do they cover their care?
yeah, I mean, sort of a hodgepodge. So essentially, if you are a non-disabled adult in Alabama that doesn't have children, you cannot qualify for Medicaid. No matter how low your income is. And so, and yeah, so I mean, so some of them buy really bad marketplace plans, so which should be outlawed, like some of the junk plans.
Well, it was for a minute. Like, I mean, that was one of the big benefits when people said that you lost insurance under Obamacare. It was like, no, it's just not legal to print insurance on a piece of paper and then sell it to people anymore.
Yes.
But those never really plans that you could eke any care. You could never really milk any blood from that turnip.
Yep.
But those were the plans that got criticized as going away under Obamacare, which a lot of that's been rolled back, unfortunately.
Yes, exactly. So actually, UAB stopped accepting one of those United Healthcare junk plans because it was so bad. And so if you have that plan, all of your appointments at UAB have been canceled. And so they will not let you step foot in the door. So I have a couple of patients who signed up for that plan, unfortunately. And so I won't be able to see them at UAB. And so, yeah, signing up for bad plans, that's one thing people do. Just being uninsured, that's another thing. So, sometimes if you're within Jefferson County, you may be able to access Cooper Green services. If you're outside of Jefferson County at UAB, you can apply for charity care at UAB, which is somewhat onerous and doesn't really cover everything, but at least it's some sort of stopgap. But I would say, a lot of those people are just uninsured. And so those are the people I see at Equal Access Birmingham, which is like our student run free health clinic. And it's good. There we can see a lot of patients who have, high blood pressure, diabetes, and generally can manage it fairly well. UAB has another clinic called the PATH Clinic for patients with diabetes, where they can get free medications if they're uninsured and they have poorly controlled diabetes. So there's like some of these options, but for instance, at the free health clinic, we can't do any cancer screening. So it's like talking about preventive health care, none of those are covered. We can see you, check your blood pressure, check your blood sugar, give you some medications for free. We don't have a comprehensive formulary, but yeah, so it's like, no, it's not a good situation. So you can maybe cobble together some sort of plan, but it's not optimal. And that's what happened. So I have appreciated getting to see these patients who are uninsured or underinsured at the free clinic, because I really then see a lot of the barriers, and almost all the patients I see at the free health clinic work. There's so few who don't work, but a lot of them are, doing things that are like landscaping or working in service industries like restaurants, or, just working just at working part-time because they're caring for an aging parent or something like that. So I would say it would be interesting to know the statistics. I don't know them, but I would say just anecdotally, most of these people are working that I see at the free clinic, and yet they still don't have access to insurance. So we're good.
Yeah.
Well, and a lot of I can hear like, the comments on this already about, well, who's going to pay for it or whatever. And the thing is, there is in medicine hard decisions, that I don't know that I'm equipped to solve. If somebody's getting close to the end of life and they're already, 85 and they need $1 million of care or something, those are hard questions. A lot of these questions aren't hard. I mean, you mentioned albuterol in the beginning. It's not like it helps anybody. It's not like it even saves that much money. Like there's not a reason to do any of this stuff. And in most cases, it's more expensive for the state. So the people saying like, well, who's going to pay for it? You will pay less. We will give you money. Just listen, get a Q-tip.
Right.
The like albuterol is, an asthma med. It's an anaphylaxis med. No one is like, well, yeah, a lot of free healthcare. Let me go to the buffet, and it's been a long weekend, and let me, like what is the reason to withhold this thing that is old as dirt, generic, cheap to make, and a emergency life-saving med that is not abusable, has a long expiration? Like, what is the reason? Why do that other than just you have the power to do it, and you want to see what you can get away with?
And I mean, the who's paying for it question is really interesting. You're exactly right. You are. So, I mean, the taxpayers of Jefferson County are funding Cooper Green. UAB is passing costs along to you when it gives a lot of care away for free, charity care. And that's very complicated because it's a tax, it's a nonprofit, and that's very complicated. So we don't.
The nonprofit of UHSF that is only designed to help the for-profit of UAB make money.
Right.
Yeah. So
it's legal. It's not. They're not doing anything wrong.
Yeah, I can't. I don't know what to really say about that. But the answer is more preventive care. And I just because it's like, if you don't care for that person's type 1 diabetes, they're going to need a kidney transplant in 10 years. So what's going to happen is they have kidney failure because of their type 1 diabetes. Then they go on dialysis. And so then they automatically qualify for Medicare. So then you as a taxpayer are paying for that. And then hopefully they can get off of their dialysis and get a transplant. At which point then they stop qualifying for Medicare, Medicaid, because they're no longer disabled by being on dialysis. And then hopefully they can keep their transplant, through some means. But it's really messed up. Other states have seen so much benefit from Medicaid expansion. I was really excited last year when our state lawmakers heard from North Carolina and Arkansas about the successes of expansion in those states. And they were like, yes, it's wonderful. It's saving rural hospitals. It's like saving lives. There was one congressman from North Carolina, a Republican congressman from a rural district, who basically said, I was against this, but as soon as it passed, I had all my constituents coming up to me, thanking me and saying I had a relative, I had a friend who benefited from this. And so his mind had been changed. And earlier this year, before the presidential election, Blue Cross was coming in saying like, hey, we might be able to do a partnership with you, a public-private partnership, like essentially what All Kids is in Alabama, but we could do that for adults, which is what was done in Arkansas. And so it was like there was hope when there was still kind of thoughts that there would be federal dollars, coming in if Medicaid expansion occurred. And now that that's in question because of federal funding cuts in the budget, I think that that's not going to be politically tenable. But it was really exciting that there was actually some hope, because I think, there's just too many stories to count of people who would be positively impacted by this that I see literally every day. So.
Well, and so before I did private practice, I was with UAB React, which is an assertive community treatment team, and we take, and talking to the viewer too, even if you guys know what these are, but they take some of the worst cases of psychotic mental illness that are very expensive. And one of the reasons why Medicaid pays more for that, a lot of those patients have been embraced multiple times. You usually have a severe mental illness, but also comorbid with something else like an addiction or personality disorder. And it really takes a lot to be on that team. They don't just take anybody. And a lot of the time, patients that have schizophrenia or addiction or something, they're going to the ER a lot, and then that's really expensive. So assertive community treatment teams were this model to bring down the cost, because if we can pay a little bit of a stipend for apartment and show somebody how to get on SSDI so that they can pay for the apartment and some of the and just have medication and become stable, they become cheaper. Because if they're homeless, there's court costs, there's law enforcement costs, there's property values going down, there's panhandling, there's maybe crime, there's all of these things. Not accounting for any of that. The team had been around a while, and a couple years before I was on it, there was a doctor who was from New York and was doing some research paper and asked if they got permission from UAB to go through the data. And a team like that has a couple social workers, which I know don't make much because I was on it. Nurses and a psychiatrist. So they're not terribly expensive. It's about, depending on how they're staffed, 12 to 15 people. They can see about 13 people per person on that team per year. And the doctor went and looked at all of it and was like, you guys are saving just in Medicaid, because she could go through the data, like about $1 million per person for the state. So
Yeah.
for the $30,000 you pay me, or $34,000, you're getting, and I could see 5 to 7 people, you're essentially saving $5 to $7 million. I mean, that investment is unreal. I mean, to pay $34,000 and save 5 to 7 million, and you've got 2 of these teams in the state, and you're fighting to shut them down, and you're saying like, well, why are all these social workers, whatever? Why is it the basic economics people that pretend that this is about money? It clearly is not about money.
No, 100%. So I have several React patients in my clinic. I just saw one on Friday, and she is so sweet, but has had a lot of abuse and abusive head trauma, and has mental illness and intellectual disability. And, prior to being on React, was in the ED all the time, just like with little complaints. But, like when you don't have any education and you're worried about your body, you go to the emergency room because you're scared. And now she hasn't been to the emergency room in like years, and she comes to see me often. She has some pain, but we got her set up with aquatic physical therapy, and her workers make sure she gets to that, and she's feeling so much better. Doing a lot of healthy habits, and like she's just like thriving. And I see that in a lot of my React patients. Like the React program is wonderful. And you're exactly right. It's not about saving money, because we know preventive care and things like that save money. It's about, I don't know what it's about. I think it's sometimes about racism, sometimes about who deserves things in our state, in our society.
Well, no one has enough, and as you cut these benefits and you create a crisis, I mean, people I think get angry enough that they're like, well, fine, I'm just going to blow the whole thing up. And that's what you're doing. When you can take more and more preventative gateways away and you force the whole system into crisis, you put everything on emergency care. And emergency care is incredibly expensive and also not designed to treat things like dialysis and diabetes medication and just everything preventative, cholesterol,
Yeah, it's so wild because in so many social issues, there isn't the infrastructure, there isn't the evidence-based, research that says these care teams are impactful. But in medicine, we know a lot of that works. We've seen it work. We've seen it work in other states. We know that it can be beneficial, and yet we still cannot move the needle forward in trying to help individuals, politicians look and understand that these measures, if we're treating them up front, is going to reduce costs, going to reduce workload, going to reduce trauma. I mean, I think about the medical trauma that these patients experience, just to stay with the example of the albuterol. If you have a patient who uses albuterol and gets that treatment up front and it gets that support, they're not having to interface with the medical system as much, versus what you were saying, they're not getting what they need. And so now they're having to have chronic conditions managed and going to the hospital and the ER, and the medical trauma that those individuals experience, as well as your medical teams, your medical professionals, because they are put into crisis, like everything's on fire all the time. It's hurry, 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 fix this, but it's like, you can't put a Band-Aid on a bullet wound. So, I mean, I think those things are important to think about as well.
Dr. Eckenrode, could you speak a little bit to, because we're talking about some issues with private insurance and some issues with Medicaid, and they're both important, and people may not know how that works, but there's some overlap in that. Like the Medicaid expansion you're talking about, it's kind of like saving for retirement. Like you pay money into it, and your employer matches you. Alabama is leaving a lot of money on the table by not investing in these things because they get the money back. And then the relationship between, I think a lot of people think, oh, Medicaid just does its own thing, and then private insurance is over here, which isn't really true. Medicaid is going to be kind of the gold standard of like how to chart and the way the system is thinking. And then insurance is going to reflect that. I mean, our practice has to try and predict what's going to happen because it means that we need to change the way that we do things. And to do that, you look at what did Medicaid do? Now, what is Blue Cross Federal doing in DC? And then you know that the plans that are the state Blue Cross plans are going to be a reflection of that eventually. And insurance just says all the time, we're going to do this. This is a new policy. Everybody, and things that are like really life changing. And then most of them don't happen. But one of the best ways to kind of predict what an insurance company will do is look where Medicaid's going. Could you talk a little bit about the economics of that for people that may not be familiar?
Yeah, and so I think private insurers look at Medicaid, but also Medicare, and so Medicaid is governmental insurance for low income and disabled people, and mostly in Alabama it's for disabled adults, and that is who qualifies for Medicaid, and then Medicare obviously for people. Some people who are disabled can qualify for Medicare, and so can get Medicare before the age of 65. That's a little complicated, but for most people, it's people who get insurance after 65. And then for some qualifying conditions, like I mentioned, if you go on dialysis, you qualify for Medicare. So, So Medicare and Medicaid and like the Centers for Medicare, Medicaid Services, CMS, they do set a lot of kind of policy precedents for what medications are going to be paid for. And yeah, private insurers definitely look to those. And so, private insurers, I think sometimes people are like, I have Blue Cross. And it's like, oh gosh, what does that mean? Like, because state employee Blue Cross is different from federal Blue Cross is different from specific employer plans that are contracted with Blue Cross. And so I think patients don't understand that like there's a lot of diversity within employer sponsored plans and within private insurance plans. But yeah, they do look to Medicaid and Medicare to see sort of coverage. And like I said before, Medicaid actually has pretty good prescription drug coverage. And so for a wide variety of conditions. So like I rarely have it be the case that I want to prescribe something to a patient with Medicaid that they're not going to cover it. So prescription drug coverage is pretty good. There are some things that they don't pay for, like they don't pay for home health. So Medicaid doesn't pay for home health, which is really a challenge if you have a patient who needs an in-home health service. And so there's definitely some limitations. There's also limitations for who accepts Medicaid. So a lot of we have a lot of struggles getting patients in for physical therapy and occupational therapy because that only hospital associated practices will see patients with Medicaid for those services. And so there's challenges with Medicaid, but overall it's pretty good. I think private insurance actually tends to be more of the issue when we're thinking about drug coverage, which I think is the thing that impacts most patients is drug affordability and cost and things. And so those companies are trying to save money. And so they have a big incentive to deny a lot of medications. And so it was a private company who required a prior authorization for albuterol. And so those companies are, very much trying to save money, trying to cut costs. They're also, I think, trying to make it difficult for patients and physicians so that they just give up. So like, there are, you could maybe get this covered, but it's so onerous to get it covered that you're just going to give up. And so I don't really see that with Medicaid, which is nice. It's pretty clear what's covered with Medicaid too. So there's a list called a formulary that you can look at and see if it's going to be covered. If it's going to require prior authorization, where there's nothing like that for private insurers. So you kind of have to guess, you're like, I hope this is covered. It may be covered. And then you prescribe it, and then it's like, oh no, it's not covered. And then it's like, well, what is covered? And then like, well, you don't know. Your patient's gonna have to call the insurance company and ask them what's covered for all this.
And then they still don't tell you. I mean, that's
Yeah.
for every time they put enough bureaucracy in front of you and what you want, then there's less people that are going to complete it, and then there's more money that they get to keep. And so, I mean, a lot of what you're talking about, I mean, I went through with my doctor, like, you've got 7 medications, you have no idea which one they cover, but it took you 3 weeks to figure out after 3 referrals that they weren't going to cover this one. So, 3 times 7, is that how many weeks you need of the doctor's time to try and, I mean, I luckily had a doctor that was willing to work with me and, wanted to fight with the insurance company. But I mean, we see a lot of people at our practice saying that they want to leave healthcare because of the amount of paperwork. And the amount of paperwork, I mean, I think over documentation and bureaucracies is a thing that medicine has always kind of leaned into. But most of the growth in paperwork, just the explosion in documentation that is getting doctors burned out and leaving the profession, comes from private insurance companies recently.
Yes, yeah, it 100% does. And it's just like, it's so frustrating for everyone. And it's just, it really impedes care. And I mean, it's like, why aren't all generic medicines just covered? They're cheap. Like, why should I ever have to do a prior authorization for a blood pressure medicine that was approved in like 1988? It's like, this has been around. It's good. It's like, why? Like, I don't know. There's no rationale. And it has to do, I know, with like the contracts that private insurers have with like drug companies, and there's like all a lot of complexity there too. But it's just, there's no reason why healthcare companies should be billion dollar businesses and like, be paying their executives tens of millions of dollars, like when they won't cover like a generic blood pressure medicine, or they will cover it, but you have to do a lot of paperwork and have a phone call with a peer-to-peer, to talk about it. It's really sad. And sometimes I just want like my patients to shadow me and like be like, come and like see. And like most of my patients are sweet and they're like understanding and I communicate with them. But like, I just want like everyone to come and like shadow and just be like, this is what it's like. And like, we are trying to do our best. I think most doctors are really trying to do their best to take care of patients and to fight for patients. But it is hard to have the energy to do it every day. So,
well, and if requiring prior authorizations or referrals for things that seem unrelated, like if somebody has a sexual assault and they want to go to therapy, why does the insurance company tell them that they have to go get their cholesterol checked first and wait 6 months, when we know that the faster you get care for trauma, the cheaper it is for the insurance company to treat? Because the faster you get better, you make a trauma sit for 7 months so that I can go see my primary care doctor to get a referral to go to therapy. That means that trauma has festered and is statistically going to do more damage to your life and neurobiology.
Yeah, 100%. And there was just a law passed in Alabama that you can see a physical therapist without a referral, which is awesome. But then like practically some insurers are still saying, no, you actually need a referral. And it's like, well, this is a law saying you don't need a referral. And like, if you like tweak your knee while playing basketball, like it's okay, just go see a physical therapist. And if they, if they're like, oh, this isn't getting better, like go and see your doctor. And then like maybe you need some imaging or whatever. But it's like, it should be the same way for therapy as well. Like if something bad happens to you, a death or a job loss, like that you just want to maybe talk about it and seek therapy, and why can't you go and do that directly? It's crazy. Like, therapy is not a harmful intervention. It's not like we're saying like patients should be able to go and buy like fentanyl at the pharmacy. Like it's not a harmful intervention to like get therapy. It's just crazy.
Yeah, it's not an abusable, addictive.
No.
I mean, it's so clear. It's so evident that it's such a predatory model, particularly for low-income individuals, because you think about just all these phone calls and conversations and points of contact. That's, if you have the time around your 2 or 3 jobs or 4 jobs that you're working, and, how much mental capacity do you have for that? Are you a parent? Do you have other responsibilities? I mean, most people can't just sit on the phone all day and try to get this $4 prescription covered, that would be life-changing for them. I think it's set up for people to fail and to give up, and it doesn't need to be that way.
No, it doesn't. Yeah, yeah, really at every turn it feels very broken. I think like why I'm such an advocate for Medicaid expansion is that like it makes things better for people. Like, and I just see it so clearly when people are able to get on reliable insurance and get that primary care and get their chronic conditions treated. Like, it's an intervention that is so impactful. And it's not perfect. Like I said, Medicaid doesn't cover everything. Like, but it's so much better than nothing. Where patients are using the ED or not, or getting really sick, and so it's such like I don't know how to fix private insurers. Like I think that needs to be there needs to be massive reform there. So, and I don't know how to do that, but I do know, like from my own personal experience, and then also from all the data from other states with Medicaid expansion, like it does good stuff. It saves rural hospitals, it saves lives, it saves money. It's like all the good stuff. So from the economics people, we know it saves money, and then for the bleeding heart people, we said, no, it saves lives. So it's like, it should be something that we're all, all on the same page for.
Well, and the people that moves the needle on so many like secondary issues that the people who claim that it's about money claim to care about, like a highly qualified workforce, like encouraging people to work because they actually, if you can't afford a car, an apartment, and insurance in America, why would you work? You kind of need those things to function. And then property values. I mean, what do you want to look at what the difference is in states where, Medicaid is there and the amount of people that move there and invest in those places? I mean, these things matter, and this is basic economics. So don't say that and then advocate for these things when you can't look at a pie chart. It's objective data. We have it. It's not an opinion.
No, and it's hard because it's like we want and need people to work low wage jobs. Like you want your people to work at McDonald's or work at a gas station or work at these places because as a consumer you want to have those things. You want to be able to get gas and not wait in line. You don't want to wait in line at fast food, all that kind of those things. But like most of those employees aren't given full-time schedules that would entitle them to health insurance. And so it's like, if you want society to function as it's functioning, you should want those people to be able to work there and yet still stay healthy. It's a win-win. And so I think like, yeah, it just comes back to the fallacy that poor people don't work hard, and so therefore don't deserve anything. And so I think that that's just a core misunderstanding that a lot of people have, or they think I've worked really hard to get what I have, other people can do the same thing. And it's just that classic mentality that I think was ushered in the Reagan era and like really has been really sticky and hard to debunk.
Yeah, so I remember like in the 90s, all the way back then, like that people were talking about the cost of healthcare getting to this point where it would just not be sustainable, and that it would be the big corporations that would say we want a public option or we want more regulation on insurance, or it's something that kind of count, because the pendulum it couldn't swing so far the other way that there would have to be some way where the federal government was getting more involved and the cost of insurance were more kind of spread out and shared, a public option or something. And that eventually this will have to happen was the conversation then, because it's so unsustainable and it's becoming so cumbersome that it'll happen when the corporations want it to, because they're the ones with all the money and the lobbyists. It seems like now they're just being like, well, everyone's going to be a gig worker. Everyone's going to be working for cash at a bar. Everyone's going to be working food service. You're going to be delivering Uber Eats and till your 40s. You're going to be delivering Amazon package, prime, whatever contractor. And insurance just isn't part of the American dream. I guess you just need to die. And they sort of bypass that thing. It's not the system is more sustainable. It's just that like we have less hope, which is terrifying. I don't know.
No, it's so true. I think we have less hope. I think people can be working really hard and not have a good quality of life. And I think somehow decided that that's okay. Yeah, I think of I have I have what I've seen. I mentioned that I have patients who like lose insurance and then I don't see them for a while and then they kind of come back. And sometimes when they come back, they are working at Amazon warehouses and they do have insurance because that job pays $15 an hour or more. But working there is so predatory. So I often see patients with repetitive use injuries. I had to write a letter for a pregnant woman to say that she could use the bathroom more than like once every like 3 hours or something that she was allotted to, because like everything they do is timed. And so it's like it's awful. Like I've seen the really bad impacts of Amazon my patients in terms of their health, but they want it because it does have health insurance and it's this carrot that they dangle, and it's just like it's such a catch-22 that if you're poorly educated or a poor person, like it is nearly impossible for you to find a good stable job that with health benefits that is that allows you to have a good quality of life. Like it's very, very hard. I just don't really see it. Like, people are, either working. Yeah, I have this woman who works at a big national corporation and they can't keep employees because they don't pay them well. So she's working like 70 hours a week and filling in shifts and her employees are suffering and she's working really hard and she does have benefits, but it's like, at a cost. So yeah, it's healthcare is embedded in a lot of larger other issues.
Well, I guess, and it's kind of a final question for you guys because both are encountering policy. I mean, I don't see like a great political path. I mean, there's like definitely parties that are like more a party that is like more hostile to any kind of regulation, but it's not like I see the Democratic Party really running with any of this stuff either. I mean, sometimes they kind of give it lip service, but there's nothing that really happens. It seems like it behooves everybody who has any kind of power to just sort of squat in front of the levers that control this stuff and pretend that they kind of want to press them, but when they have the ability to do it, just not. And so what do you think is effective? I mean, what is effective at getting things to be different? Is that more of a kind of community, bottom up approach? Is it a different way to coerce power to do something that it should? I mean, what do you feel like works?
Yeah, well, I mean, I do like there are states where there's a lot of intransigence against kind of pro people policies, and Alabama is one of those states. I mean, and so I do think that does have to do with political party alignment. I mean, I just like we as a state seem to be like pretty okay with a lot of like human rights abuses and things like that. And so like I think about our like state prison system and like convict and like policies that still exist. I talking about prison healthcare is a totally separate, terrifying thing. Anyways, that we could do another episode about. But anyway, yeah. So I think like I do think that what is the solution? I mean, the solution to like underinsurance is Medicaid expansion, and it's worked in other states. And so it's like our state like just has to listen to the testimony of other similar southern states, like North Carolina, that in Arkansas, and just has to decide like this is what we want, this is good for people. But I think it's so hard because our state lawmakers don't really seem to like necessarily want to do what's good for people. They want to advance agendas that are I think just meant to, I don't know, really.
It's like pandering to national politics locally, where it's like this has nothing to do with what it was like to live in Birmingham or Mobile or Florence, Alabama.
Yes.
Why are you talking about this national stuff?
Yes. Exactly.
Which you're talking about the Reagan era, but I think I saw that happen too as a kid when Clinton came in and Gingrich was basically like all politics are national now. These are the two football teams, and before that, it really was like, all right, I want to vote for the comptroller. Here's the Democrat. Here's the Republican. I'm a Republican, but the Democrat has these ideas. I like that. It's a comptroller. Why would I care what he thinks about the president?
Yes.
And it sort of did become football around that Reagan, Thatcher, 80s, 90s realignment.
Yeah, no, totally agree with you. I think the answer is keeping politics local and getting involved in kind of local. And that's like what I decided to try to do, like, personally, when I was just like, gosh, this feels really hopeless. Like, what are some things that I can do? And like getting involved in organizations like Alabama Rise, Alabama
Mhm.
Appleseed, that like are doing things that are clearly good. Like Alabama Appleseed, got rid of the the idea that jail managers could basically pocket extra money that was left over in the food budget after feeding inmates. And so that led
I
to like,
remember those articles.
yeah,
This sheriff
yeah,
pocketed like $200,000
yeah,
feeding potato
Wow.
flakes from
exactly.
Sam's
So,
Club to the
and
prisoners.
I think like anyone across like the political like divide can be like, that's not good. Like, like we can't starve
When
people.
also it's like comically funny. Like I don't care what your
Mhm.
politics are. Like some of this stuff is like so horrible. Like can't
Yeah,
we just laugh at
Mhm.
it
yeah,
together and agree
right,
that it's
exactly.
Yeah.
bad?
Together and change it. And so like that is what I think the answer is. I think the answer is like, hey, let's try to like make things better in small ways, or like reducing the grocery tax that we're slowly chipping.
Yeah.
Nobody wants to pay grocery tax. I remember coming here and being like, what? There's grocery tax? Like Pennsylvania doesn't tax groceries, it doesn't tax clothes, like, it doesn't tax essential items. And like I was like, wow, living here is like a 10% increase in paying for groceries, and that's a lot. So yeah, so I think like the answer is coming together on small issues that everyone can agree on, because like everyone can agree on stuff, like you said, sometimes it's funny, but sometimes it's just like grocery tax, like no one wants to pay this, like it doesn't make sense, let's try to get rid of that. And so I think that's the answer right now. Maybe things will change and we'll have less political division and there will be better answers, but the answer right now I think is to work on these smaller things.
Well, I think
Yeah.
I hear like a lot of opining about how like there's so much political dissension and hostility and we're more divided or something. And it's just kind of like, I mean, maybe like we are, but the real political issues, I hear everybody saying the same thing about. Like
Mhm.
it's almost like we
Mhm.
mistook politics for something else. Like when I
Mhm.
see people talking about manners, they're like, well, this guy's rude or this guy's whatever. And it's like materially, what did they do? Like I don't care if
Yeah.
you like if they talk like you and look like you and whatever. Like, did they do something that you like? And there's this kind of need to make politicians, I think, like Marvel superheroes, where they're like, no, you elect people that go out and inspire and they represent, and then the kids look at them and like, no, like they're not supposed to be cool. They're supposed to make roads and food.
Mhm.
And if they haven't done that, I don't care. Like, that's their job.
Yeah.
And
Yeah.
I don't know. So it's almost like it may not be that big of a realignment. It may just be a focusing on what everybody cares about, and instead of this kind of game.
Yes,
Yeah.
no, I totally agree. And that's kind of what I tried to do with this article, was try to like appeal to people to be like, look, like there, all of you know someone who would benefit from Medicaid expansion. Everyone who's reading this, I think, would think, oh, there's someone I know who would have benefited from this. And so like if that's the case, like let's all band together and help our fellow citizens who need this help. And so like that's what I wanted to do with the article, was kind of just try to encourage people to think like, oh, there are these people in these situations that need help, and they may not need help forever, but they need help now. And like if we want a healthy, economically strong state, like that's what we can all work to do. So to do this thing. So anyway.
Well,
Yeah.
thank you so much. I want to be respectful of you guys' time. So is there anything that we don't get to that you want to put in at the end? And can you also give me the links to those organizations so that I can put those in the show notes, and anything else that people might want to check out after listening to this?
Yeah, I definitely can. I can, oh, sorry. I can put those.
Then you don't have to do it now. Just I want to make sure listeners know that they can get more information about that if they're interested.
Yeah. Alabama
And
Rise is great.
Yeah.
They do a really good job of keeping everyone informed and up to date on what those core issues are that are currently happening, and when to lobby and who to talk to, and when to show up at the state house and all those things. So they really are doing a lot of the work that I think a lot of people don't want when they're like, oh, I don't want to get involved in that because I don't know how. They do a lot of the how and really support you in being able to really actively engage in a political way that's meaningful.
Yeah.
Anything we don't get to that you feel like is information that is relevant and it needs to be included?
Yeah, I just would like get back to like encouraging people to not be hopeless about politics and to kind of just say like, yeah, Alabama Rise or Alabama Appleseed, just learning about bills that are in the state house, calling your state legislators. That feels really good to be civically active, and you can, turn the needle. So there was just a law about age of parental consent for teens receiving healthcare services. And it was going to go from 14 to 18, which would have been challenging for a lot of teens who like are going to the doctor like alone because they can drive, or like they have a grandparent who's more involved in their care, and like, but they're not the legal guardian. So, and through a lot of advocacy, that law was brought down from 18 to 16, which is good. So that cannot impede access to care for teens. So that's just an example of like there was advocacy surrounding that in the medical community, and that was changed. So like you can make a difference with issues that matter to you, not these huge issues probably like private insurance, but smaller ones that are also important. So I would just encourage people to not be hopeless and to get engaged with more local or more state-based organizations.
Yeah, and I think too, one of the reasons I wanted to celebrate your article and say thank you is a lot of times there's a culture in medicine with medical doctors where they don't want to break ranks, and I understand like a lot of the reasons why they don't, because there's a ton of liability in basically criticizing your colleagues or saying different things, but it contributes to that problem of people being hostile to doctors and people not understanding, because the person at the top of the private insurance company that's rejecting the thing ultimately has a medical degree, and when the doctors who are in it for the right reasons don't criticize that because of a fear of liability and the same reasons a lot of people don't speak out, I think it reinforces that problem. And to kind of have these conversations and be open and honest about an economy of ideas, and to be able to kind of have free discussion and debate around these things is important. It's important for medical professionals to say these things, and not just after you've gone on NPR and written the book and you have millions of dollars and it doesn't matter. At the beginning of your career, the middle of your career. We really appreciate what you did and what you continue to do.
Thank you. Yeah, I think I want my patients to know that I care for them. I think they do know that. But that most doctors do care a lot for their patients. But yeah, I think sometimes there's a fear of speaking out, and I guess UAB could fire me, but I could primary care is in demand. I could go job somewhere else. But I don't think they will. But yeah, I think it's important for patients to know what we're going through too, and that there are barriers, and a lot of doctors burn out and then go work for United Healthcare, which is the largest employer of doctors in the country. And it's so sad. So whenever I end a peer-to-peer,
the chicken or the egg,
yeah, whenever I end a peer-to-peer with them, I always say, I hope you appreciate that what you're doing is contributing to burnout for doctors like me who are actually caring for patients, and like I hope you feel bad about that. And that's how I end with my peer-to-peers, and if that makes you feel good, that's like a little thing that I can do.
I was on the phone with somebody. My wife glared at me, but I was on the phone with somebody with a tech support bureaucracy thing, and I was explaining something to them, and they were like, "What do you want?" And I was like, "I just want you to feel bad."
Yeah, right. I know. I just like, yeah. And when retired doctors do that, it kills me. I'm just like, what the heck? Like, you should find some other side gig, like driving for Uber or something. Like, this is not what you should be doing.
Well, thank you so much for coming on. This was a joy. Hopefully we can do this again around other topics. We were hoping to have the podcast studio by this point, but connecting visually works pretty well. So hopefully we can do kind of more local issues and local guests. And we really appreciate your work. You can find out more information about Haley and her practice on the Taproot website. And then we will link to everything that Dr. Eckenrode mentioned, and then also her practice page in the show notes too, if y'all want to check that out. The next podcast will be a guided meditation on anger. No relationship between the content here and next episode is completely random series of. So enjoy that, and we will hopefully talk to you again soon.
Thank you so much. It was really fun to talk to you both, and have a good rest of your day.
Listening